Good evening, everybody. I welcome you in the evening of second day of Healthcare Transformation Summit, the second edition by Elets Technomedia and supported by Mylan Pharmaceuticals. And this in this Healthcare Transformation Summit, there is a concurrent event, which is a knowledge exchange conclave on infectious diseases control, supported by Mylan Pharmaceuticals. And here today, we are discussing in this panel discussion, part of the Knowledge Exchange series, on the topic Public Health Strategies to Control Infectious Diseases. And we are honored to have a very eminent panel with us and very vibrant panel with us to discuss on this very crucial issue when the world is facing COVID-19 pandemic. And at the same time, we are facing the TB, hepatitis, HIV, all infectious diseases we have to manage at the same time when we are managing COVID-19. And the country is doing the same as well. So what is happening and what to do and how to go further, how to exchange the best idea, the best work happening in the sector. We have these experts talking to us in next 1 hour about it. So I'll just introduce all the eminent speakers before I start the discussion. I welcome Dr. Harshad Thakur, Director of National Institute of Health and Family Welfare, Government of India. Welcome, sir. And
good evening, everyone.
Yeah. I welcome Dr. Prem Singh, State Nodal Officer of National Health Mission, Government of Rajasthan. Dr. Prem Singh, आपका स्वागत है.
Good evening to all. Thank you.
I also welcome Mr. Sanjeev Dham, who is the COO, Chief Operating Officer of Smile Foundation. Sanjeev ji, welcome.
Good evening to everyone.
I welcome Dr. Dilip Patil, co-founder, director of Trivector Group and Baby Quest Cryobank Group. Dr. Dilip Patil, आपका स्वागत है. We also have with us a very eminent personality, Dr. Vikas Oswal, senior pulmonologist and consultant chest physician, National Anti-EP trainer and Governor Maharashtra Chest Council of India. Dr. Vikas Oswal, आपका स्वागत है. Okay, so now we will be moving on to the discussion, and I'll ask for initial remarks for 4 to 5 minutes from each of you, and I'll start with Dr. Harshad Thakur. Sir, please share your thoughts.
Okay, good evening, everyone, and I congratulate organizers for taking this topic on very important topic. And since last few months, our focus is on COVID-19 pandemic, and we are trying to control the pandemic. And I am happy that due to this, we are also refocusing on our public health. So this has given us opportunity to focus also on public health. So side by side, when we are managing COVID-19, we are also trying to create awareness about other diseases. So basically, since this is broadly about all the infectious diseases, and I will just like to give brief that mainly in infectious diseases, we have various miscategories. So airborne diseases, then waterborne, then you have contact transmission through direct contact. Broadly, you will have direct transmission and indirect transmission. And COVID-19 has features of both direct and indirect transmission. And if you talk about public health strategies, so public health strategies are quite broad. When we are trying to identify patients and trying to treat them, we are trying to only focus on secondary prevention. So we are trying only to control the patient, the disease occurring in the patient. But at the same time, we have to see broadly, because every time when the a person becomes a patient, he is in the incubation stage. So during that incubation stage, he might have transmitted his disease. If it is infectious, if it is infectious disease, he might have transmitted disease to many other persons unknowingly. So that we have to take into account, and that is why this contact tracing comes into place. So contact tracing is one of the important public health initiative. Then when we are trying to isolate the patient, we are trying to see that when the patient is in transmission phase, the patient is not transmitting the disease uh, to those who are coming into his contact. If the patient is severe, already a serious condition, already he will be in ward in ICU, and obviously the chances of transmitting is quite less. The most dangerous situation is when patient is not affected by serious disease, he is affected by mild disease, or sometimes there are no clinical signs and symptoms. So that times the patient is unknowingly transmitting the disease whenever he is going into open community. So that is where the major problem comes in, and we have already seen in COVID pandemic that we are adopting strategies like physical distancing, social distancing, and wearing of mask. So these are the strategies when unknowingly you are getting the disease, and this will affect many other people when they are actually not suffering from the disease, but there is a possibility that they might come into contact with somebody who is having the disease. So this is where our main primary prevention comes into picture. So here our main strategy is to see that when you are not affected by the disease, you are trying to take precautions so that knowingly or unknowingly you will not get the transmission from, or you will not come into contact with the person who is having the disease. So this COVID-19 is only one disease. So it has features of direct transmission, indirect transmission. So similarly, we have various other infectious diseases. So if you talk about sexually transmitted diseases, then this is transmitted by various different patterns. Then there are diseases transmitted by blood transfusion, or when you are coming into contact with hospital waste. So that is also another thing. Then there are diseases transmitted and you are coming into contact when it is a waterborne disease. So waterborne disease like hepatitis A, typhoid. So these diseases, again, you are trying to, you might get the disease again through various ways. For example, through unhygienic food, or when you are indiscriminately eating from various places which might have got contamination. So, uh, uh, so when you are talking about, basically my point is when you are talking about prevention strategies, public health strategies. So in primary prevention, it might not be clinical strategy. So there might be many other aspects rather than clinical. The only clinical aspect is vaccination. So when you are giving vaccine, either live vaccine or attenuated vaccine, that time it is a clinical way. But other time you will have to see that there are social factors, cultural factors, behavioral factors, environmental factors, which are taken care. There is also public health engineering. So that means that you are taking care about safe drinking water, basic sanitation facilities, or your immediate environment, keeping it clean, hygienic, and also this air pollution. So when you are trying to keep air as much free from contaminant as possible. So all these things play a very important role. So social factors, environmental factors, even engineering factors, your housing conditions, your neighborhood conditions, and also the other factor which we have seen in COVID-19 is creating awareness. So awareness is also important. So in COVID-19, we have created enough awareness about diseases transmitted through this airborne route or airborne route. So basically similar diseases like TB and all. But also we have to see that we create awareness also about other types of infectious diseases. That is also important, and that creating awareness is the most tough job. You cannot create awareness only through English media or Hindi media, not only through audio or visual. So there are various ways, various strategies, and we have to also see that public health comes into this aspect. So media plays very important role, and you cannot deny that. And you will also have to see that there are various languages, various misconception, myth that are playing role. So again, in COVID-19, we have seen the fear pandemic or fear psychosis. So we have to see that when you are creating awareness, you are not unknowingly transmitting the fear also. So that is also very important. And here also media plays very important role. Uh, so basically, there are various stakeholders, and all of them they have to
Right.
play their role. So we have private health providers, government health providers, uh, media or other common man, NGOs. So all these they have to play their role. It should be like a intersectoral coordination, and also we have to take into account the common man. So I think I will
Right.
stop here because you have given only 4 to 5 minutes. Maybe later on I will come in. Thank you.
Thank you, Dr. Thakur. I understand that we have this topic has a lot to discuss on, but we have a time constraint. But you actually stressed upon a very important part that everybody has to work together, and the stakeholders which you mentioned, most of them are here with us in the discussion. So you talked about NGOs. So I'll just go to an NGO representative here, Mr. Sanjeev Dham, Chief Operating Officer from Smile Foundation. Sanjeev ji, how an NGO perspective can you tell us on infectious disease control?
Thank you, Karthik, for inviting. And firstly, I appreciate Elets for providing a virtual platform to exchange our views at this trying time of our life. I would like to start with one simple line. I believe if you want to solve a problem, then it's important to recognize there is a problem. If you don't recognize, then means that we will not able to solve the problem. I think so. We are talking about infectious disease. In my opinion, if any country want to solve infectious disease, that means very clearly there are various issues which I think so. Earlier, Dr. Saab talked about communicable, non-communicable, and infectious disease also. But I think so important here is strengthening the primary healthcare system is a key to control, including I would say the infectious disease through the prevention, screening, testing, and curative. These are basically well-known facts. The important is how robust our primary healthcare systems is. I just wanted to make our point of an organization. So we as an organization running nearly 40 mobile health unit, we call it a Smile on Wheels, to complement the government efforts as to provide the primary health care in urban slums and rural areas, and also running the telemedicine centers across Rajasthan as well as in Delhi and Kolkata. So these are basically few centers that is being supported by the various donors to complement and supplement the government's efforts to ensure the primary health care is robust and reaching out to the underserved population. That's going to be the critical to control this infectious disease. And that, at this point of time when that, government is, facing a huge challenge in terms of this pandemic, it become apparent that whether when they we face this pandemic in the month of March, whether it's a all health system, including public and private, was not geared up to handle this situation because our testing facilities was not ready to take care of that. Entire health system face, in my opinion, two key challenges. Whether it's a COVID, whether it's a TB, whether it's a hepatitis, any infectious disease we talk about, in my opinion, there are two forefront issues that come. How to make masses aware, which I think so Dr. Saab mentioned that is a very critical. So behavior change, communication with evidence. We need to understand through the research that is why people are changing their behavior because of certain reasons. There are triggers for that. And people who are not changing their behavior, there are barriers for that. If we scientifically identify those barriers and triggers and work on them in a professional fashion to talk about the preventive piece, then I think so we can solve a lot of problem. But I know that it's a easier said and done. We are not going to reach all of the population because 130 crore population we need to reach out, we can't reach out. That means the second piece which is forefront come to us is that curative services and structural referral system. That's a very very critical if we want to control all the infectious disease, whether it's a hepatitis, whether it's a TB or it's a COVID, whatever it is. I think so. That is, I think so, very, very critical if we talk about that and strengthen that piece. And the challenge is very clearly is COVID has changed our you know lifestyle. We are now living in new norms. Why? Because it's been shaken us by the media, by the way that government has acted and enacted. And I think so that is the one of the reason behind all that, stakeholders going to work together. Then I think so we can change the system. That's, in my opinion, is very critical to deal with all the infectious disease, including, I would say, the COVID. So we have a progress. If you look at, we faced this pandemic in a month of March, but now it's an important to acknowledge. Presently, we able to do 15 lakh testing in a day for COVID, because all the forces are working together to achieve certain goal and objective. So now home quarantine is acceptable way of asymptomatic patient. Increasing the number of facilities is there. Earlier that we were not having that facilities of PP kit as well as the ventilator. Now we are exporting. So why this has happened? Because whole system is geared up. So my only point I want to emphasize again and again, system has to geared up. How? That means that we need to adopt a new innovations. And why I'm saying innovation is a critical, because we need to think about out of the box. It's not that everything is going to treat in the hospital. It is not necessary that everybody has to reach to the hospital. The government was sitting on the telemedicine policy, in my opinion, for so long. But this pandemic, they have approved, I think, so in a couple of days. So that is my point I wanted to make again and again. It's an important that we need to, policy need to be updated. Policy has to be such that has to be the customer friendly. When I say customer, when they patient friendly. So that means now the doctor can, give services through the teleconsultation, through the telemedicine. So these are audio and video are acceptable norm of that. The prescription can go through that, WhatsApp, and through the SMS also being acceptable. So those are the changes is required in all that, the work that we are doing, especially for the infectious disease. And the last and important point is that the post-COVID, are we thinking about, which is very, very softer piece, is the counseling. And as an organization, we have started a program called Baaton Baaton Mein Sehat, which is a tele-counseling, especially for underprivileged community people who are living in slums. So they need to access that. Because of this, the post-COVID people have need a counseling. The post-COVID, there is a huge effect on their other issues they are facing. That has to be addressed. In my opinion, that the trauma, there is a stigma that is being attached. How we are going to solve that? That is also, in my opinion, the huge challenge for us that we need to address. And I think so that is only, in my opinion, is a way that we need to reach out as digital. Maybe some point of time we need to vary a system as per the local need. The customized approach has to be there based on the local need. We need to modify our system and to ensure that we're reaching out to the target audience, and people who are most vulnerable. It's more important. They are going to spread most. So I think so we need to tackle first them. So that means the bottom of the pyramid, how we are going to reach out. That should be, in my opinion, the answer is reaching out to the rural population, reaching out to the urban slums. That is going to be the solve the most of the problem. So people who cannot afford the services, how we are going to reach out and make our services accessible to them is going to be the winning for any of the infectious disease. That's I want to say, and rest my he
Thank
talks
you.
here.
Thank you, Sanjeev ji, and rightly mentioned. And reaching out is very important, and I think we all are working towards it in reaching out to the people. And from academic perspective to NGO perspective, now let me go to the medical perspective of it. I will go to you, Dr. Vikas Oswal. Dr. Vikas, you are working on TB patients and for a very long time. And so, what is your opinion about TB and COVID treatment synergies? And give your initial thoughts for 4 to 5 minutes.
Yeah, first I would like to thank the organizers for giving an opportunity to join over here on this dais. We all are facing, we all are struggling since March onwards with this lockdown, this COVID era, and this is nothing new for us. The struggle was not a new for us, if you ask me. If you ask me, really, we are struggling not only for COVID, but initially it was tuberculosis, and this COVID is now. So we have faced a lot of challenges. We have overcome a lot of challenges for tuberculosis. We had to make many alternative arrangements because of the socio-economic status of the country, the drugs which are expensive, the reachability of these drugs, uninterrupted treatment for these drugs, for the medications for drug-resistant tuberculosis. All these challenges were already been overcome to the great extent with a very good collaboration, if you ask me, between the NGO, private and public. Treating tuberculosis was not easy only with public sector. It was not even easy only with the private sector. And then came the NGO. So when there was a good collaboration between these three sectors together, that was only the time when we were able to reach a maximum best outcome. That is what we have seen, at least in our area in Mumbai. Mumbai being the highest DRTB resistant cases in India, all over India. But the time when all these three organizations came together, that is NGO, private and public, that was the time when we had proved the best outcome. And then came the COVID, where in COVID, the all the facilities were again crashed down. The treatment, giving medications to the needy, supply, uninterrupted supply to door for all the patients was a major challenge for us. You know, because patients were unable to come and reach to the OPD services. Patients were afraid to reach the clinics. Clinics were shut down. All the clinics were been converted from TB to COVID. That was again a next challenge. And then availability of our staff. So all these challenges were had to overcome. We had to overcome all these challenges. Treatment, but initially we thought that there would have been lot of, we were expecting lot of COVID in our ward, but surprisingly, the TB patients in our ward right now, there are around 8,000 resistant tuberculosis just in two wards, that is two districts in one ward. Out of the 8,000, we were expecting n number of COVID, these all these 8,000 to convert into COVID, but we were being proven wrong when we saw our isolation center separate, which was been made for a COVID and TB coexistence patients, which were lying vacant for around 2 months and 3 months. That struck us that yes, there is something to do with immune system of a TB patient, which is not allowing COVID to get to enter the system. Maybe already there is existing tuberculosis in the system. There is some sort of immune system going on, the host system, host response going on in the body, where COVID is unable to be positive over there. So these TB patients who were already on AKT, not only sensitive but also the resistant TB patients, the number of COVID in them, the co-infection of TB and COVID was really less in our area. So this was been confirmed not only in one ward, but reconfirmed by the rest wards also, that the patients who are already on AKT were not showing that much of positivity for COVID. And then came the trial. Second thing was also the, if you see the mortality of children because of COVID is really less in case of developing countries like India, where there is already a BCG vaccination which has been given from day one for our children less than 5 years. The mortality for COVID is really less compared to the mortality of children due to COVID in a developed country where there is no use of BCG vaccination. So again, this gave an idea of coming up with some trial for a better outcome of BCG maybe it would be helpful in case of adults also, which the ICMR recently have come up with a paper right now where 60 to 80 years of adult being given BCG have shown out to have some better outcome. So the same trial has been also been conducted in the age group, other age groups, that is less than 60 years also. So very soon even that results will be out. So let's see. So challenges are definitely there, but this were been overcome in cases of tuberculosis. But now in COVID era, we had shifted somewhere from the clinics to the virtual treatment. That is, we had made a maximum use of teleconsultations, telecommunications. We had come up with some applications or the software where patient would join online, and the history taking and the regimen making, everything would have been done online, and we are just managing these patients online, not only for tuberculosis, but we are also screening all the patients of tuberculosis for COVID. And if there are a co-infection of COVID and tuberculosis, we are trying to give them a maximum care at home itself. Home quarantine being official right now. Initially, it was only tuberculosis. Now it is COVID and tuberculosis, but the services have not been stopped. Notification had gone down to a great extent, which again have started coming up with the services where we are providing online for TB and COVID both together. So we have
Right.
tried our maximum to do for not only COVID, but TB as COVID both together.
Right, right, Dr. Vikas, thank you so much. And you actually gave us some very interesting facts, and interesting to know that how COVID-19 and TB treatment happening together, and how you are using online for this. That's great. And when we talk of TB, Naresh Hasija ji, Mylan has a strong presence in TB control in India. How do you see the TB treatment in India in this COVID-19 era? Your initial remarks.
So, I think overall, as we were talking about infectious disease, overall, I see that Milan has been playing a very, very active role in managing, starting from HIV, working with government on elimination of viral hepatitis and then elimination of tuberculosis. Now we have entered in the space of COVID by introducing remdesivir. So I will say that we have a comprehensive strategy, and we believe in you should have, like you have in this panel, you have starting from diagnosis, you have a social civil society in the place, you have government, you have medical fraternity, where we can really, when all of us can come together, I think we can create a real difference. This we saw while we were working with many state governments on elimination of viral hepatitis. A landmark work was done in that space with few state governments, and then central government took up the program, and now we have a national scheme on elimination of viral hepatitis. So similar work, now you can see that in India HIV patients are going down, and as well as tuberculosis. Now, as Dr. Vikas very well explained, how COVID has impacted tuberculosis in both the aspects he presented. Like we had enough sufficient inventory, but it could not be utilized because of a. I heard this for the first time because of a new different immune system in TB patient. So these are actually good learnings for all of us. I really would like to learn a lot from this panel, which is very, very eminent people are there. And I will say that, yes, a comprehensive strategy end to end with all the stakeholders can play a big role in eliminating infectious disease. Thank you. Yeah, Arshad, thank you.
Right, right, Mr. Asija. Yeah, Mr. Asija. Yeah, thank you. There was some networking glitch at my end, I guess. Thank you so much, Hasida ji. And when we talk of TB, we always have in our mind an airborne infection, which causes TB at large scale. And we have an expert who is working extensively on airborne infection, has a lot of innovative ideas and works to do with the airborne infection. Mr. Dilip Patil, founder of Trivector Group. Dilip ji, I would like to ask you that how to control this airborne infection, how to kill it. You have this solution with you. Please tell us about that. And your initial remarks in 4 to 5 minutes.
Okay. Good evening, Karthik. Thank you for having me here. Actually, COVID-19 has really opened up lot of things. As the previous speaker said, we have to follow the new norms now. Means the things which we never thought of have to be done as a primary thing now. So since I diversified from infertility line to infection control in 2015, I was struggling to let the healthcare workers, healthcare administrators, and to tell the people that just hand hygiene and surface cleaning is not enough to control the hospital-acquired infection. You have to treat the air. Air is one of the major thing in spreading the infection. And in fact, there was not much awareness about airborne infection. Even the hospitals, even the infection control departments, they were in denial. They were saying that we are taking precautions with hand hygiene and surface cleaning, and we have all the protocols. And they used to downplay the airborne infection. I mean, so they say we have HEPA filters and we are doing these. And means first 3-4 years, I was struggling to make aware about airborne infection control. That airborne infection, and especially country which is having the highest incidence of tuberculosis in the world. And Mumbai, as my previous speaker said, Dr. Vikas Agarwal, that Mumbai is the capital of MDR TB in the world. Actually, Mumbai has the highest number of patients, so it's all airborne. So during COVID, before COVID, that's exactly what our company used to say, that airborne infection is one of the main thing. And we have solutions. As you said, we have innovative solutions. We are out of the box solutions, which are sustainable, which are green solutions, which are economical solutions to scrub the air, to disinfect the air continuously and prophylactically, and then to avoid the spread of infection from person to person, from facility to facility. We have introduced way back in 2015 a technology based on plasma to sterilize the air. Means we are having we all know that medical sterilizers for equipment sterilization, we use the plasma. We use some chemicals, hydrogen peroxide, thing to generate the plasma. But here, our technology actually uses the infected air as the medium of plasma. It charges the air, and all the pathogens in the air are decimated, are killed, or are totally destructed at the DNA level. And then this technology has been proven to be effective. We have done at least 30 independent institutes have done the validation, clinical validation study, including NASA in America, and including on TB, influenza, and then very recently we have done the validation study even on COVID-19 surrogate. This technology can kill, can eliminate within microseconds. When it comes in contact with that plasma field. Even COVID-19, SARS-CoV-2 virus or surrogate of that. That's how it has been tested in America. So we have a research paper. So COVID has provided us that platform, that the acceptance or the awareness about airborne infection, that there are some airborne infections and we should be careful. And COVID has really opened up our eyes to the airborne infection. Unfortunately, till June end, there was a lot of confusion, even within WHO and CDC, that whether it is airborne or contact. They were insisting that it is not airborne, it is not totally airborne, it's only contact based. And then it took them 3 to 4 months to accept that it is airborne, and that it is airborne. That's the proof enough that we have to have 6 feet distance, social distancing. We have to have the mask. So that means it should not spread in the air. And then we have papers. Papers suggesting that airborne COVID or SARS-CoV-2 can be there for several hours up to days together in the air. So we have to take care of the airborne infection. And I will talk more about our solution if time permits. This is my initial remark. And then regarding TB, Dr. Vikas Agarwal said, so it's a blessing in disguise that India has such a big problem of TB, but then due to COVID, the precautions which we are taking, or rather which are now we are adopting, we are imbibing in ourselves to take care of airborne infections. They are so good, so effective for tuberculosis, spread of to contain the spread of tuberculosis, that I think our goal of reaching that NETP or National End TB project by 2025 or 2030, whatever, I think it will. This COVID was a blessing for the TB
Yes.
program, that we may control the TB sooner than expected. That's my
Right.
hopeful thinking. Thank you.
Right, right. Thank you so much, Mr. Deep Patil. You have been always been very innovative and with your solutions, and I understand that in infection control also you have been doing great work. And now I'll come to Dr. Ravindra M. Mehta. He is with us. He's senior consultant in pulmonology and critical care in Apollo Hospitals, Bengaluru. Dr. Ravindra, welcome to this panel, and we request your initial remarks in 4 to 5 minutes, and please share your experience in infectious disease control.
Yeah, so the reason thing I was asked to come on was to talk of some post-COVID issues and so on. Do you want me to just present a brief
Yes,
slide presentation on that?
yes, you can, sir. But if you just keep it in 5 minutes, if possible, sir, we'll come back to you with more questions then, so
Yes,
that because we have more time.
I can edit it. That's not a problem. Can you see my screen?
Yes, 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 we can.
Sure. So in the next 5 minutes, we'll try and come out with some of these things. So these things are reiterating, I think, aspects of the COVID virus. At the same time, bringing up some interesting issues for the future space. May not directly be related to infectious disease as the prior speakers have so wonderfully elucidated, but it pretty much puts things into perspective for each one of us. So basically, the respiratory and systemic onslaught, what we suffered from was the whole spectrum of COVID, which is still being debated. This data came in from China, but this data was pretty similar to any other infectious disease. And currently, we're going through this right now, where in the north, especially, we see that as the winter sets in, we're going to be dealing with regular viruses and so on and so forth. And so the whole thing was, when compared to other infections, how is COVID going to be differentiated? And if you look at this conglomeration of symptoms, when you have fever, cough, body ache, sore throat, diarrhea, and so on and so forth, it's going to be quite challenging to try and figure out which is which out here. So as numbers go ramping up in Delhi now, it's going to be quite a healthcare and system issue to try and deal with all these. And then came the spectrum of disease of COVID, which we realized was a big eye opener, which also now is something we'll have to figure out as other viruses come into our spectrum. We like this asymptomatic part, which went to the home isolation protocols, which Dr. Oswal was mentioning. And this patient who initially used to be in the hospital, but now has been relegated to being at home. But the most worrisome part where we got completely swept was when the pneumonia part kicked in, which required hospitalization and maybe horrible things like intensive care, which each one of us has dealt with, and which has been the bane of the pandemic. So much as on one side we've had a low case fatality rate and a low attack rate, the denominator has been so massive for people afflicted that we've had to deal with this. And now with a fresh round of regular bugs who are also coming to take their share in the disease spectrum of mankind, we'll be dealing with all these things at the same time, hopefully not in the same numbers as we saw. In the COVID pandemic, we saw this also. We saw how horrible the X-rays got and how the pneumonia was spreading, to the point that we have said that in dedicated COVID hospitals like ours, we have this unusual, unique, and hopefully never said again statement: all patients in one hospital, one diagnosis, and everybody looked similar with similar issues and so on. And so it is a task. It is a spectacle we've never seen before. And more CT scans have happened in this pandemic than ever before. Before we used to hesitate to get scans, and now they're happening left, right, and center, like routine events when it came to trying to approach COVID patients. What about patients with pre-existing lung disease, which is another problem now and which was talked about earlier, and we'll have to deal with this. Let's not forget that our infectious lung disease and our non-infectious, non-communicable lung diseases also are an issue out here. And so these comorbidities are constantly playing the dance with COVID. And chronic lung disease and smoking is something which will get worse in the winter also when it comes to bacterial and viral infections. And another thing we'll have to deal with as we go by. So it's interesting how it's like turning the pages of a book and different chapters which open up when you look at the stages of COVID and how we'll be dealing with COVID, other infections, and where each one will be playing a role over here. For example, we've given so much steroids to patients, And so, as Vikas Oswal was pointing out, we'll probably have much more immune impact of that, and we may have later infections, especially tuberculosis, which may come down the line, thanks to all sorts of such therapies. We've used a whole bunch of machines, which has also, both been a challenge, a nightmare, at the same time has familiarized people with these, and all sorts of things like this, what's called this high flow nasal cannula, more advanced non-invasive ventilation, and then the invasive ventilator, and these fancy things like ECMO, which came after SP Balasubramanian mentioned it. All these have been used rapidly in massive numbers and to an extent never seen before in this COVID pandemic. Then the post-COVID syndromes, which is basically a thing which has now cropped up. The West was talking about it, but now we are also looking at it because we've reached that stage. Mumbai started and all of us are catching up. It's a disease with a long tail, and there's many issues because of the multi-system nature, which are going to come up now. The technical term given by the Italians is, by the Western people, is long COVID. And because the symptoms start continue long after COVID is gone, and they put a very nice paper out there where they said that only 13% people are actually free of COVID-related symptoms down the line. So this will be something we'll have to factor in again. And so these have to be a major part of what public health and all of us have to deal with. And more data is coming out that cough, fever, dyspnea, or shortness of breath, all will be part of what we have to tackle. Infectious disease also will come in the picture. So our usual chikungunyas and malarias and dengues, which also come to us, especially as the rains are going on in places like the south and Bangalore, is going to be part of the challenges we deal with when we jump on COVID, but we cannot relegate these other infections to the background. Pulmonary fibrosis or scarring is a part of what we are also worried about, that when so many people are getting lung damage, should we be concerned about it? Another important area of work is going on at this point. And to summarize this whole quick discussion with this presentation, it's a respiratory virus with protean involvement. And now the post-COVID syndromes is going to be a challenge. The infectious component of what's going to come down the line and multiple infections which will coexist is going to be another thing we'll have to deal with. Consequences of the post-COVID syndrome are myriad and manifold, and something which will come into the spectrum of society in general and healthcare in particular. And I think this old normal, the good old infections of the past, will be very difficult to look at as we now look at the interplay happening between COVID and all these things. And certainly any effort in this direction is welcome, as this particular forum is trying to project with all these august dignitaries adding their perspective in the midst of how we try to wing all these things. So thank you very much. I'll stop sharing my screen.
Great, Dr. Ravinder. In very short time, you actually highlighted a lot of important things, and one of those things is how to deal with post-COVID issues. And I'll come back to Naresh Hathiaji on this, but before that, we have one state government representative here with us, Dr. Prem Singh. Dr. Prem Singh is State Nodal Officer for National Health Mission. Dr. Prem Singh is State Nodal Officer for National Health Mission, Government of Rajasthan. Prem Singh ji, tell us how the Rajasthan government is reaching out to people for COVID-19 control.
Thank you. Thank you giving this virtual platform to share my views. Basically, I'm in implementation field, and how we are tackling this COVID situation or infectious disease in the state. So I say that minimizing transmission of infectious disease is core function of public health or government. Or so how government is taking how the prevention of infection disease strategies is it is response of disease outbreaks told us, and government is also reactive role in supporting access of treatment as we are doing in COVID era, and even authorizing public health authorities to limit or to exercise their powers to control the infections. So these are major major strategy through which governments tackle the infections control or I say problems. It is well said by Sanjeev Dham sir that we should strong in primary health care, reach out to last people, use of new technology and consultations, and Vikas is also told about reaching out the last people or last persons. So, for regarding this, the state governments is having the systems of immunizations, and you are all aware about universal immunization program where we provide vaccines of seven diseases like tuberculosis, pulmonaritis, hepatitis B, diarrhea, and pertussis, and etc. And similarly, state is working for and preparing database for COVID-19 vaccination. As soon it will come in the pictures, and the state will be ready to vaccinate those people on their as per Government of India priority lists. So this is the this way the immunizations will go. And second is the screening of individuals. So now I think that everyone is aware about how the screening process, because after many years this COVID pandemics happen, and now every people are well aware about this screening programs of governments, and this is through media and through reaching out by primary healthcare workers. So how how government are reaching the governments, how state governments are reaching. Governments have systems of ASA workers. ASA workers, those are they are social health activists, and they are also helping to management of COVID patients. And we have also a team of NM nurses and doctors as a rapid response teams who are going going on infections areas and doing screening survey, and also treating them. And if there is treating them to control the process. And if you talk about systems, we talk about systems. So there is a systems of integrated disease surveillance project which is launched by Union Health Ministry in 2004 for up to 2010, which is still continue. It's having objective to strengthen, maintain, or decentralized laboratory-based IT-enabled disease surveillance systems to epidemic-prone diseases, to monitor disease trends and detect and respond the outbreaks in early rising phase through the trained rapid response team. So this is the IDSP system. IDSP is having a central unit, central surveillance unit, then state surveillance unit, then district surveillance unit, and downside in the field that district hospitals, sub-district hospitals, community health centers, primary health care, sub-health centers. They are having their reporting format like P form for presumptive disease, L form for lab test, and even a form to report present cases who are under infection or under monitors. So this is the reporting system, and this unit is very specifically specially trained peoples like epidemiologist, microbiologist, and entomologists are the team in the state level, and supported by data management team and even people from procurement and finance to tackle the systems. So this is the IDSP systems, how it works, and it is also having very supported by National Informatics Systems and ISRO to manage their data and their internet connectivity and reporting systems. So this is this way the IDSP is working in the states and national level, and I say that every state level. And now I like to knowledge the panels about most I say that most new things is happening in the field, that is Ayushman Bharat. That is under Ayushman Bharat is health and wellness center. Just like talk by Sanjeev Dham is about comprehensive primary health care. So still in phase of in this era, and we are running 2020. We are still struggling with control of infectious disease such as diarrhea, and well told by Vikas about tuberculosis and such common diseases which we can treat. But there is no system, but there is no established system, or say no established manpower in the field levels to reach the last people. So health wellness center concepts now I will tell in 1 minutes. There's the health wellness center is going to I say that it will be function on sub health center, and sub health center is led by a community health officer, which are who is a background of nursing background or bachelor of Ayurveda and medicine surgery backgrounds, and got training of 6 month bridge course. Probably this training is for in public health field. So and the team is consist 2 ANMs, ANM, or I say multi-purpose health worker, and 3 to 4 ASAs. So there's a big team at 5,000 population to tackle the screening and these issues. So this is a health wellness center. What is the role and what is functions further, I will talk in next.
Yes, Dr. Prem, thank you for very insightfully telling us that how IDSP is working in states and how also these wellness centers are working. And this is all about reaching out to people. So I'll come to you, Naresh Hasijaji, that Mylan has a strong presence in public health ecosystem of India. I would like to ask you that one topic which Mr. Ravindra Mehta, Dr. Ravindra Mehta talked about is post-COVID, dealing with post-COVID situation. What about that? And then I will also like you to like to ask you on how to reaching out to people, how to ensure medicine accessibility, how to ensure capacity building of the people. So on these 2 points, if you can throw some light.
Thank you, Karthik. It's very interesting. I think it was really a surprise more of what are the after consequences of COVID. In my own team, like gentlemen working on
Hello, Mr. Hastija. Is it the problem at my end, or we lost connection with Mr. Hastija?
We have lost connection with Mr. Asija.
Okay, he's back.
So I was just telling about our own experience where our own employee working on remdesivir, who was day and night working on COVID, and he was experiencing COVID, and we saw that post-COVID effects were really, really not good. And then at that time we decided like how to really work and make sure people who are coming out of COVID, they are really taken care. So that was the time I think we shaped up a program called Panacea, and this program was launched last week as a platform where we will be giving. This is a digital platform where we will be not only coaching, taking care of the patients about their yoga, their mental health, their nutritional health, as well as we have actually taken it to a next level now after discussion with a lot of group of hospitals here in India. Their key suggestion is it is not only about mental as well as your physical health. It is actually, in some cases, COVID is affecting organs also. So we really wanted to involve senior pulmonologists of India. We want to involve endocrinologists, and we really want to make sure we do a good justice to this population who is coming out of COVID. So more we get into webinars, when we learn a lot from each, and I think this strengthens us, and we are very, very committed, and because we are the most patient-centric company, and we feel, I think we should do a real justice to COVID care. So coming to the second point, like what I will say that Sanjeev was saying in his communication about if we get into structural referral system. I think Dr. Oswal will really vouch for it. We have a fantastic referral system developed by TB board here in India. I think it's a very, very good program where public-private partnership, a lot of models are existing and we are doing very well. It can be a fantastic example for COVID. You can see that as well as for viral hepatitis. In viral hepatitis, I remember the national program, when we were having a meetings with national program, we were struggling to provide proper diagnostics at that time. For viral load, we used to find that it takes 4 to 5 days for viral load reports to come, and there was no right facilities. Sample will go to a larger lab. So, but now with COVID, you can see that how Atmanirbhar we all have become now. Whether it is diagnostic, whether it is treatment, whether it is hospital care, we have totally become Atmanirbhar, and this is one of the fantastic example of public-private partnership where everybody has come forward and created a comprehensive program. So I will pause here. Thank you.
Thank you, Mr. Astija. Dr. Vikas Oswal, I will come to you. There is always we have seen accessibility to drug, accessibility to the medicine is always been an issue. There are a lot of issues of drug access for DRDV drugs across India. So, what is your suggestion on how we make it more robust infrastructure in terms of this access of drugs?
Uh, I myself have been a very part of this development program over here in Mumbai, because initially Mumbai was the accessibility of these drugs, medications was really a major challenge, where patient had to travel. There was only one single unit, the Shivri TB Hospital, which is a very known hospital in all over India, a good TB group hospital, where all the patients ready to be any part of Mumbai, they had to travel to Shivri TB Hospital, take an appointment over there. With the OPD used to be conducted once in a week, and from there they used to get medications. And then he used to travel every day from Shivri TB to, let it be, even Bhainder, Borivali, which is around good 15-20 kilometers away from the center. And when this need was been assessed, the necessity was been assessed, there came a solution that why not we come up with some different Shivri hospitals everywhere. And then we had joined hands with NGO, and this collaboration was been made, that is NGO based private public partnership model, which came into existence in Shatabdi Hospital. Right now, if you ask me, that is a part of a decentralization basically where we came up. And this decentralization was very important. Unless you come up with a decentralization model, the success of this assessment of the drugs or assessment of drugs won't be very frank. So at Shatabdi Hospital right now, we are the leading people over there, where around 120 patients are on the newer drugs, Delaminate, and not only that, around 500 patients are on Bedaquiline. And you will be surprised to listen this, that each and every patient have been dispensed these medications on OPD basis. None of the patients were being admitted, because initially there was a rule that if the patient is drug-resistant tuberculosis, he need to get admitted for around 10 days or 15 days. And we used to assess the patient, we used to assess the side effects of the medications, we used to give them for 15 days, observe them, and then we used to release them in the field, which was been broken. The practice of this admission was been broken by us, and we were the first in India to come up with an OPD based dispensing of the medications. Each and every patients were being dispensed, even Delaminate and Bedaquiline, on OPD basis. We never admitted any of the patient. Admission rate at our center right now, where we are managing 8,000 plus drug-resistant TB patients from 3 districts, one single Shatabdi hospital, are right now catering 8,000 plus DRTB patients, and each and every patients are being managed on OPD basis only. So these drugs were being given to in their own wards, which is very important. Similarly, similar model can be practiced ahead. Why only one Shatabdi? Now I would come up with, let us come up with 10 different Shatabdis. Let these Shatabdis be there in every single wards of Mumbai. That is what even I was been proposing to Milan also, that why don't we come up with this similar model? Let us come up with an apex body which is made up of a good private public model, and this apex body then take up such model in each and every ward. But why patient need to travel in this separate ward also? So let us just come up with some different committees, and these committees, let us install these committees, train these committees in every hospitals, and let
Right.
these committees then make a regimen for the patient, where patient need not travel any other, need not cross their wards, and they get easy accessibilities to these drugs in their ward itself. Our guideline is already have given a green signal for OPD based management right now, which is very great thing. The newer guidelines, the PMDT, where even I am one of the part of the I am one of the editors in these new PMDT guidelines also. We have given a green signal on all oral regimen on OPD basis, but still implementation is yet poor. I do not know why still physicians are finding it difficult or struggling it still to dispense these medications on OPD basis. So somewhere we are lacking on sensitization of these physicians. So we need to now overcome these challenges by sensitizing these test physicians and physicians more and more, along with the grass level root workers like health visitors and the SDPS and the STOs, SDPS and the DTOs and the medical officers in the wards. We
Right.
need to train them more, so that we come up with a small clinics everywhere, where the accessibility of these drugs, dispensing of these drugs will be very easy, and the reachability will be to the remotest area also. So unless this has been made, it is not going to be that easy. So I
Right.
think there are physicians who are well trained. So let us just make an apex committee and install them in each and every ward, so that they become the committees to dispense medications, and there should be a central committee who would take care of these committees. So this is
Right.
somewhere
Right.
I would see a good future, and I think it is
Right.
not an impossible model.
Yeah, thank you, Dr. Vikas, for sharing these great ideas. And reachability is still an issue. I would like to ask you, Mr. Sanjeev Dham. Mr. Dham, if you are here, you have listened to all these challenges: reachability, access to drugs, post-COVID treatment of people. How an NGO can work with a company like Mylan Pharmaceuticals, a provider, and a medical stakeholder like Dr. Vikas. How an NGO plays a role here, Mr. Sajeev Dham. And I'll
I think
also
so. Yeah.
take it as your closing remarks.
Yeah, thank you. I think so. Vikas has made very important point. Public-private partnership, that's a very critical. I think so. The important piece is that how to we create a bridge. In my opinion, is one of the model which is not related to infectious disease, but any of that the public-private partnership that we wanted to have. There are the two partners, how they need to be come together, and how that they are going to be, their whole business model is going to be created. In my opinion, it should be on performance based, how that outcome based funding model need to be created, so that each patient is being cured, is being funding model can be created, or the government should also come forward, and that the private sector also come forward and say, okay, fine, this is the way forward. So very clearly the patient treatment is the final outcome. On the basis of that, the whole business model is being created. So we really clearly see the outcome based funding model is going to be the way forward. That's a very important model, because why I'm saying it is very close to my heart. The first impact bond that I launched in Rajasthan, and I part of the design team aim to launch that, and now that I am in a different role at a different organization, but I see that it is very popular in most of countries, developed countries, that the impact bond model, that is going to be the critical to going forward to bring the public private partnership together. And whether infectious disease, whether communicable, or whether it's a non-communicable, but especially for the infectious disease, that the compliance is drug compliance is very, very critical, and for where the drug compliance is important, so somewhere the community need to be involved, whether it's the public health system or any system that has to be created within the community. So that system has to work together and has to be monitored, and monitoring is going to be the key. In my opinion, the digital is only the way forward to track that. and that's way I think so we need to
Right.
go forward that. And I'm not going to go into detail of that, but I'm talking the broad contours of that piece is on one-to-one basis offline we can talk about. But I'm very impressed the way that Dr. Vikas explained about the model in Mumbai, because I know that that particular model itself, and I was part of the journey initially of that particular model when the BMGF started funding on that particular project which Dr. Vikas is talking about. I never got a chance to meet Vikas, but I know about this model, and I was part of that another organization to bid for that. So basically, it's an important that we need to talk about a performance-based business model to take care of this forward. That's all I want to say. Rest here.
Thank you, Mr.
Yes,
Sanjeev.
yeah. Vikas,
Vikas.
Vikas want to say something, I believe.
I want to add something over here. Sorry, last 1 minute. This partnership, never gets successful if it is only private-public partnership. They have never been successful unless there is a channel in between, that is a term NGO. So there is no term basically NGO-based private-public partnership. There is no term coined. Since that is my own term which I use always, it should always be NGO-based private-public partnership model gives you the best outcome. Reason being is private physicians don't have direct communication with public sector always, because we cannot be running behind public sector. Public sector don't have only one single infectious disease to take care of. They have many diseases under their umbrella where they cannot focus every time that with that focus, one single focus. So that is the key role where NGO plays a major role over here. So if we convey with NGO, they convey it to the public sector, and they try to solve and balance the thing, between both. So unless these three sectors come together, achieving any this thing is not going to be that easy. Is what I feel. So NGO definitely has got a very big role over here, to key role rather, to make both these sectors to join together.
Thank you, Vikas.
Right. Thank you, Vikas. And I will now come to Mr. Dilip Patil. Mr. Patil, you listen to all these stakeholders. Your closing remarks, please, Mr. Dilip Patil.
Sorry, I was on a call.
Yes.
So, as a closing remark, as a person working in airborne infection control, I will always say that now that COVID has opened our eyes for airborne infection, so we have to take care of disinfecting the air, and then we have to adapt the new technologies. We have to come out of our old mindsets that whatever we have is enough. We have HEPA filters, we have centralized HVAC system, but mind you, it is not enough because viruses like COVID, they are not filtered by HEPA filters. They are neither killed by ionizers or anything like that. So they have to be totally decimated, and then you have to adapt to the effective killing technology which are friendlier on environment, which are less consuming of electrical power, and then user friendly, means it can be used around the patient 24/7. And I think that is the way forward, along with whatever we are already doing, hand hygiene and surface cleaning and social distancing, everything. But then I think we have to be very careful about cleaning the air, because airborne infection is also a big cause of deaths in India. Air pollution is a really big problem. So that's my closing remark. I'm sorry, I'm not able to show you how the machine works, and we have already installed hundreds of these machines in COVID hospitals all across the world, and also in India actually. So maybe next time I can
definitely next time.
As Mr. Naresh Hasija said, we have to work together. All the stakeholders have to work together towards this eradicating this problem, and I really appreciate this sentiment. Thank you very much, Mr. Hasija.
Right, Doctor. Thank you, Mr. Dilip Patil. Dr. Prem, and just 1 minute, your remarks. You're on mute.
It is good to hear NGO-based public-private partnership model and And I'm having experience to work with both. Sanjeev Tham said that he was in Rajasthan, and many PSCs are run by NGO-based public-private partnerships. And similarly, about 108 and equipment management systems are running by public-private partnership. So my remind on the PPP mode is that if your model and I say intention is to serving people or serving public health people. Here we are discussing public health strategy. We are talking about large people, not who is privileged or living in metropolitan cities or big cities. So we are talking about non-effort. So if you are having a motto or vision to serve large people, then NGO-based model, I think they are doing good nowadays. And if you're having serving with earning boards, so it is public.
Right.
PV model is good.
Doctor,
And 1 minute remark is my that still you have to do lot of in field of public health to reach the last people. We need cost effective technology. Still technology they are very costly. Even nowadays, even government can't afford. Afford for, because can't diverse all the fund towards health, and so most cost effective technology. And about medicine, if you talk about medicines, like even we are think about diarrhea, we are struggling with diarrhea, we are struggling with tuberculosis at this time. So we need more innovation, more cost effective, and more people friendly. People can accept those things. So in these lines, thank you.
Thank you, Dr. Prem. And we heard all these stakeholders. In the end, I would like to ask Mr. Hasija for closing remarks and thanking everybody also. Mr. Hasija.
So I will say that I think Dr. Vikas is very successful in driving one clear message: NGO-based public-private partnership. He has really taught all of us. It's a fantastic thing. Yeah, I appreciate that. And a good learning, Sanjeev. We are very, very keen to understand outcome-based performance model. And of course, with Dr. Vikas, we work very closely, and we would like to understand the Stabdi model, how more Stabdis can be created in India. We are very, very keen. So I will, instead of closing remarks, I will say that these are my learnings, and I will work closely with the panelists on these things.
Thank you.
Thank you.
Thank you,
very
Mr. Hasija. Thank you, Dr. Vikas, Mr. Sanjeev, Dr. Prem. And we will end with a session, a 1-minute video. And after stay here, after 1-minute video, we'll wrap up. So please play video, Deepak.
Is good enough?
Thank you.
That's what we ask ourselves at Mylan. When we see dreams getting hindered by poor health, we feel good is not good enough. When possibilities can be accessed by just a few, good is not good enough. When health comes with a condition of affordability, we know good is not good enough. For more than half a century, we at Mylan have helped create better health around the world. We market more than 7,500 quality products that help people in more than 165 countries.
Because good health gets better only when it becomes more accessible to all. At Mylan, delivering better health for a better world isn't our job, it's our mission. Mylan, better health for a better world.
Better health for better world. And before leaving, I would like to introduce that we are also working on an event, Panacea, not an event, but an activity at a longer stretch, helping overcoming your post-COVID-19 anxiety, fear, and mental trauma. It is free for all. Everybody can register for free and take these sessions for free. And Mylan Pharmaceutical has supported in this cause. And please join the audience which are here. Audience is also requested to join this. Thank you so much, eminent panelists. We wrap up here. Thank you.
Thank you.